Good morning. On behalf of my co-authors and the Early Breast Cancer Trialist Collaborative Group, I'm very pleased to present the first results from a patient-level meta-analysis of taxane with anthracycline versus taxane without anthracycline chemotherapy for early-stage breast cancer. I have no conflicts of interest. Anthracycline and taxane-based chemotherapy have been part of the standard treatment options for early-stage breast cancer for more than a decade. Previous analyses have shown that the combination reduces the risk of breast cancer mortality by about 1/3 compared to no chemotherapy. There are, however, concerns about toxicity, particularly the long-term risk of cardiovascular disease and leukemia from anthracyclines and of neuropathy from taxanes. Increasingly in clinical practice, we're seeing the use of more non-anthracycline-based chemotherapy, particularly the schedule of docetaxel and cyclophosphamide. The aims of this meta-analysis are to better characterize the benefits and risks of anthracycline and taxane chemotherapy for early-stage breast cancer. We sought patient-level data from all eligible randomized trials that started before 2012. All trials included at least 6 planned cycles of chemotherapy in each treatment arm. Primary outcomes were recurrence and cause-specific mortality, analysed by standard EBCTCG methods. We've received data for just over 18,000 participants in 16 randomised trials. Trial design varied, so we've divided the trials into 4 comparison groups. In Group A, participants were randomised to a concurrent schedule of anthracycline, docetaxel, and cyclophosphamide, compared to 6 cycles of the same cumulative dose taxane administered as docetaxel and cyclophosphamide. In Group B, participants received either a sequential anthracycline and taxane schedule or a higher cumulative dose of taxane administered as docetaxel and cyclophosphamide. In Group C, the comparison was again against a higher cumulative dose of taxane and either administered as a single agent or concurrently with capecitabine. And in Group D, the comparison was against higher cumulative dose taxane administered with carboplatin. This slide shows the results for the combined analysis from all 16 trials in Groups A to D. On the left, we have a Kaplan-Meier plot for recurrence, and we define recurrence as any first invasive local recurrence, distant recurrence, or new invasive contralateral primary. The rate ratio is 0.85, which is a 15% proportional reduction in risk of recurrence, favouring a taxane and anthracycline schedule. This is highly statistically significant, with a 10-year gain of 2.5%. On the right, for breast cancer mortality, we see a very similar rate ratio of 0.87 and a 10-year gain of 1.6%. Trial design varied, so this is a forest plot looking at the 4 comparison groups. If you look at the bottom of the plot, you'll see that there is statistically significant heterogeneity between the 4 categories. And if you look at the individual lines on the plot, you'll see that the greatest proportional reduction in risk of recurrence is for Group A, with a rate ratio of 0.58, and this is the group of concurrent anthracycline and taxane. For the remainder of the presentation, I'm going to focus just on Groups A and B, where the control arm in all trials was the same, that is 6 cycles of docetaxel and cyclophosphamide. We have individual patient data for all 11 eligible trials with just under 14,000 participants. The median follow-up is just over 5 years. And important to highlight the tumour characteristics of the participants in these trials. The majority had hormone receptor positive breast cancer, many had higher risk disease, and many had lymph node positive cancers, and very few people with HER2 positive breast cancer were included in these trials. There were also differences in cumulative doses between Groups A and B. In Group A, with the concurrent anthracycline, docetaxel, and cyclophosphamide schedule, most participants received a cumulative dose of doxorubicin of 300 milligrams per meter squared. The cumulative dose of taxane was the same in both arms at 450 milligrams per meter squared. In contrast, in the sequential anthracycline and taxane trials, most trials used epirubicin as the anthracycline at a cumulative dose of 300 milligrams per meter squared, which is approximately equivalent to 200 milligrams per meter squared of doxorubicin. The cumulative dose of taxane in the anthracycline and taxane arm was approximately 1/3 lower than in the control arm, typically 300 milligrams per meter squared of docetaxel compared to 450 milligrams per meter squared. This slide shows the comparison between groups A and B for recurrence. If we look firstly on the left at the concurrent treatment arms, we see a rate ratio of 0.58, which is a 42% proportional reduction in risk of recurrence, favouring taxane and anthracycline. This is highly statistically significant with a 10-year gain of 8.7%. However, important to highlight that in this comparison group, there were only 2,469 participants, so we have to treat the absolute numbers with caution. But if we look at the 95% confidence intervals, the lower limit of benefit for the taxane and anthracycline was 0.73, so it's likely that that combination reduces the risk of recurrence by at least 25%. In contrast, on the right for the sequential comparison group, we see a rate ratio of 0.92 and no significant difference between treatment with taxane and anthracycline compared to taxane alone. The next slide shows the same plots for breast cancer mortality. On the left for concurrent anthracycline and taxane, the rate ratio is 0.65 with a 10-year gain of 4.2%. This is again statistically significant. And on the right, there is no significant difference between taxane and anthracycline versus taxane control treatment in the sequential comparison group. Most of the differences that we're seeing for these analyses are therefore coming from Group A of concurrent anthracycline and taxane. This slide shows a subgroup plot for hormone receptor status just for comparison A. On the left for estrogen receptor negative cancers, there is a rate ratio of 0.51, and on the right for estrogen receptor positive cancers, a rate ratio of 0.66. There is no statistically significant difference between these numbers, suggesting that there is benefit from taxane and anthracycline chemotherapy in both ER negative and ER positive breast cancers. This slide shows a forest plot by nodal status, again just for comparison A, and we see no statistically significant heterogeneity between the categories and therefore no difference in proportional benefit for people with lymph node negative compared to lymph node positive breast cancer. When considering a meta-analysis for chemotherapy, it's very important that we think about the toxicity and quality of life. Looking at our combined analysis for all 16 trials, we saw no statistically significant difference in death without recurrence, with a rate ratio of 1.06. In our data, we have also seen no difference in deaths from cardiovascular disease or leukemia, but longer-term follow-up is needed. Individual patient-level data on quality of life and toxicity was not available. So in conclusion, for the combined analysis of all trials, we see a 15% proportional reduction and a 2.5% absolute reduction at 10 years in the risk of invasive recurrence for anthracycline and taxane versus taxane chemotherapy. However, a much larger proportional reduction was seen with concurrent schedules where the taxane dose was the same in both arms and the only difference was the addition of anthracycline. Little, if any, benefit was seen from sequential anthracycline and taxane chemotherapy schedules versus a higher cumulative dose of taxane in the control group. Proportional reduction in recurrence did not differ by hormone receptor status or nodal status. I'd like to finish by acknowledging the Early Breast Cancer Trialist Collaborative Group, the trialists who generously shared their data, and very importantly, the 18,200 participants in the 16 trials. Thank you.